Alaikum, everyone. Welcome to the Grand Rounds today. Today we have the pleasure to have with us Dr. Abeer Alawi. Abeer went to the med school in King Saud University between 2009 and 2014. She made an internship in the King Khaled University Hospital between 2014 and 2015. Then she made the residency in Kekesh between 2015 and 2019, and the fellowship in our institution in pediatric ophthalmology and strabismus. Now she's joining us as a consultant in pediatric ophthalmology and strabismus. She's board certified in the Saudi board and also by International Council of Ophthalmology. She's humble, talented, clever, and skilled. When we talk about the 2030 vision plan, she's one of the products of this excellent initiative. When we talk about talent, talent is cheaper than a table of salt. What separates the talented individual from the successful one is a lot of hard work. Abeer, you are talent and hard worker. Your destiny is succeed. Please enlighten us today with your lecture. Welcome, the mic is yours.
Thank you, Dr. Sisma. Such a wonderful introduction. Thank you so much. So I'm going to talk about tips in deep sclerectomy in childhood glaucoma. So there is no question that deep sclerectomy in pediatric glaucoma is effective and safe compared to conventional surgery. It has a similar success rate with a lower rate of complications in primary congenital glaucoma and in juvenile glaucoma, as well as in secondary glaucoma in children. It is becoming the procedure of choice, at least in Saudi Arabia, and it deserves to be an important alternative to conventional surgery in congenital glaucoma. It was described in the late 1950s. It is termed non-penetrating because the inner wall of Schlemm's canal, trabecular meshwork, and the Descemet membrane itself, it remains intact after surgery. It works by removing the diseased filtering system, including the Schlemm's canal and the juxtacanalicular trabecular meshwork. It has many mechanisms of action. Four are proposed. The most important one is the uveal outflow, which works through the uvea, the exposed uvea during dissection. Also, there is the subconjunctival outflow through formation of the conjunctival bleb. It also has an intrascleral filtration as well as filtration from the Schlemm's canal. So regarding the technique, it's highly dependent on the technical skills of the surgeon. It has a long learning curve. It also depends on good exposure during the surgery. So if you don't get time to do good exposure, you will have a difficult case. It also depends on a different anatomy in the primary congenital glaucoma, especially. They have a different anatomy in terms of the ill-defined limbus, the outstretched globe, ophthalmic eye, thin ocular wall. So this makes the surgery more difficult than the adult. So we start with the surgical exposure. Like all glaucoma surgeries, the surgery is performed in the superior quadrant of the globe, either temporal or nasal. And this depends on the surgeon's preference and his handedness and whether he's operating the right or left eye. I usually make a marking at 12 o'clock on the limbus to orient myself. When I do the exposure, I will rotate the globe inferior. So I have to orient myself, which is the nasal and temporal quadrant when the globe is rotated. So the 6-0 vicryl suture, traction suture in the cornea is used. So this is the video. The key point is not to go too deep you stay in the corneal stroma to prevent like penetration into the Descemet membrane and entering into the AC. You can do like 1 stitch or 2 stitch. Like in this video, there is 2 stitches. The advantage of doing 2 stitches is that in case one breaks off, you still have the other one to rotate the globe during surgery. The other advantage is shown in this video. So you can also hold or fix the scleral flap between the 2 stitches, making it better to expose and dissect without needing an assistant to hold the flap or like remove it from the surgical site. So then we go to the conjunctival flap. I usually do a fornix-based conjunctival flap in an L-shaped, inverted L-shaped flap. The advantage of doing the fornix base is better exposure at the limbus. So you have better exposure and easy access to the limbus when you're doing the dissection into the trabeculo-Descemet window. So this is the video. So I start with a radial incision in the conjunctiva, doing a cut at the limbus, and then doing dissection, nasal and temporal, subconjunctival dissection. Making sure that the space is enough to do the superficial flap with the caliper. Then some cleaning of the sclera using a tox knife, the scarifier, and cleaning the scleral vessels with a light cauterization. You don't need to do like a very aggressive cauterization to prevent scleral fibrosis. So after we're done cleaning the area, it should look something like this. Then we go on to making the superficial scleral flap. So I start by using the caliper. I mark 5 by 5 square-shaped scleral flap. Then with use of super sharp blade, I outline the scleral flap edges on both sides. You have to make like enough pressure to like go into the scleral third to have scleral thickness. Remember, they have thin ocular wall. And then you do the horizontal. You can use the super sharp blade or the crescent knife to like make an edge at one of the corners and start dissecting, maintaining the same level, doing the lateral cuts here. And try not to pull on the flap too much and maintain the same level, because if you go too superficial, you can amputate the flap or cause a tear in one of the sides. And if you go too deep, you might end up with a 1 flap deep sclerectomy. Like you will reach the Schlimm's canal very early. So maintain a good depth and same depth throughout the dissection. So you might face the scleral vessels that bleed. So you can use a mentor tip to cauterize them at this point. So you continue with advancement of the dissection until you reach the clear cornea. Again, the same depth and without too much pulling of the flap. Here's another way of making the superficial scleral flap. Dr. Ali al-Bishri, he uses a horizontal incision. Then he enters with the crescent knife in a pocket-like fashion, circular maneuvers, same depth. Okay, and then he makes a lateral cut for the edges. And there you have it, very nice flap. Another shape of superficial flap is the trapezoidal flap, using the trapezoidal marker. This is Dr. Konrad. So it doesn't make a difference whether you choose to make a trapezoidal or square-shaped flap. He uses a leather blade, MVR. So once you reach this point of dissection into the cornea, it's time to use the antifibrotic mitomycin C with soaked sponges, small sponges, 0.2 mitomycin C. You put it under the scleral flap, under the conjunctival tissue for 1 to 3 minutes, then you remove. And now it's time for irrigation. So you have to do thorough irrigation with BSS solution. Like we use 2 bottles to irrigate in the conjunctival pockets under the flap. We remove also the corneal protector. And then you go into the deep scleral flap. This is the critical point of the surgery. So you have to be careful when preparing the deep flap. You have to go deep, like 90 to 99 scleral depth. So it's a good idea to increase the magnification of the microscope, increase the illumination, and then start. So you make the deep scleral flap. Again, in the same manner, you use the super sharp blade to outline the flap. You will dissect it like 0.5 millimeters away from the superficial flap and 0.5 millimeter in the posterior part. You can use again the crescent knife or the super sharp blade to hold an edge. You have to reach like a good thickness until you reach the choroidal level, leaving only like 10% of the scleral tissue left behind. So you have to start with a good depth and like adjust the depth as you go to maintain the same level of depth toward the dissection until you reach the trabeculo-Descemet window. You can also amputate at this point or cause a perforation as you approach the trabeculo-Descemet window from too much pressure or pulling of the flap. So instead of doing like a central dissection, you can do lateral cuttings for the flap. It will help with the dissection, and the central part will be dissected spontaneously because the trabeculo-Descemet membrane will detach spontaneously from the stroma, corneal stroma, and you can do a dry sponge dissection in the center to prevent perforation. So at this point, we have good filtration. I usually don't peel the Schlemm's canal, probably because I go too deep. So the Schlemm's canal would be already removed without peeling, like it's not there. So by this time, when you have reached this depth, you reach the trabeculo-Descemet window, you're happy with the filtration and the level of dissection, you can excise the deep scleral flap using a fine Vannis scissor. Be careful not to pull too much. This is critical because perforation can happen at this stage even after like successful filtration. So no pressure and no pulling of the flap. So making the deep scleral flap, you can also, as I said, use the super sharp blade, 75 blade, like go in until you see the choroidal color, 90% thickness, and then maintain this level. So while you're dissecting the flap, the deep scleral flap, a lot of bleeders can happen, but it's not good to cauterize at this level. Instead, you can do the dissection under continuous irrigation. Because if you cauterize, it will cause scleral fibrosis. Also, the uvea can be exposed, but don't worry, you can like continue dissection, make a new level, try to keep enough scleral bed and continue dissection normally until you reach the window. So the deep scleral flap, it's all about keeping the correct depth and advancing the dissection into the trabeculo-Descemet window until you reach a good level. and it has to be done under like dry condition. If you don't have someone to assist you in to dry, you can cut small sponges and put it as you advance with the dissection. And as I said, lateral cuttings is better than the central dissection. You can use the super sharp to bevel up to do the lateral cuttings. This will enhance the filtration, and the trabeculo-Descemet membrane will like spontaneously be dissected. So also the deep flap can be done with the trapezoidal marker. Here, Dr. Konrad is using the trapezoidal marker. So this video will show Dr. Konrad doing the peeling of Schlemm canal. So he's doing it under continuous irrigation, peeling on the Schlemm's canal. And he is now using the scraper to like remove or to facilitate the peeling of Schlemm's canal. So he's peeling at the Trabeculo-Descemet window to try and get any tissue to enhance the filtration. And now you see it, he's peeling the Schlemm's canal. And you can also like do cannulation of the temporal and nasal side of the Schlemm canal using the spatula. This can also cause perforation at this level of surgery. And then with the continuous irrigation. Okay. So implants, usually we don't use implants in pediatrics because if the child is hyperactive and he will rub the eye, the implant might migrate, and at least we don't use the non-absorbable. You can use absorbable like the ologen implant. The benefit of using an implant is that it reduces the scar formation and it keeps the decompression space open, which will improve the long-term success of the procedure. So it's positioned under the superficial scleral flap, like in this example. So this is DS with ologen implant. So he just puts it after creating the deep flap and excising it, and then covers it with a superficial flap. So after all this, you can secure the superficial flap loosely using 10-0 nylon suture slip knots. So you don't have to close it too tight, it has to be loose. And whether you close it or not, you can keep it open like and just reposition the conjunctiva and suture. So closing the conjunctival flap using 9-0 BV bilateral suture. So you have to do a running suture, the L-shaped incision, and you can do anchoring suture to the other side if you like feel it's not tight enough. So you have to do a watertight closure, and then you have the diffused, modified, very nice bleb afterwards. So coming to the surgical complications of deep sclerectomy, the intraoperative ones, you can penetrate into the AC while starting the surgery with the traction suture, the corneal traction suture. So as I said, the key point is to keep in the corneal stroma. You can like use a Wixel sponge to see the entry and exit point of the needle to see if you are getting a leak or not. And this can happen without you noticing, like you will notice that the AC will shallow with time and you're not noticing the leak. So if this happens, you can do a paracentesis and inject OVD to the AC to reform, or you can just notice the leak, see that it's not significant, you can carry on with the surgery. You can also keep the needle in, if you notice the leak, keep the needle in the like cornea and use the other arm to create another traction. That's it. Or you can do stromal hydration to like close the leak. So coming to the most important and the most common complication of intraoperative DS, which is the trabeculo-Descemet membrane perforation. So this happens probably, like I said, from aggressive handling of the tissue, pressure on the trabeculo-Descemet window, pulling too much on the flap. Even if you're excising the deep flap, this can happen at the last minute of surgery. So if you have a good tip is if you have high IOP, you can try to decompress the globe by doing a paracentesis before you expose the trabeculo-Descemet window to prevent this perforation. So this is example of a micro perforation. So this, like you see the gush of fluid, like it's a micro perforation. So if it's small and no iris prolapse happened, probably you can carry on with the surgery and complete the next steps and everything will be fine. Or you can like reform the AC if you see that it's becoming shallow, reform the AC and maybe put an pilocarpine drop at the end of the surgery. But if you have a macro perforation, like the whole iris is prolapsed, now you have to convert to trabeculectomy and do a peripheral iridectomy. You have to cut full thickness of the iris and probably suture the flap tightly, not too tight, but it has to be tighter than usual, and then you carry on with a converted DS. Another complication is when you do the deep flap, but you're not deep enough. So you reach the end and there is no filtration. You're not at the correct level. You have missed the Schlemm's canal. So you can start again doing a third flap. You can either start at the choroidal level, like from the ciliary body posteriorly, again doing a third flap, or you can go directly above the Schlemm's canal and dissect a third flap until you get a filtration, then cut the two flaps, the third and the second, and that's it. The last complication is from probably poor handling of the tissue, which is the scleral flap tear. You can have a buttonhole or amputation of the scleral flap. So if it's small, you can suture a tear. If it's like too big, you can change the location of the flap or do another flap, like try to readjust the thickness and join the two flap together, the third one and one from below. If you amputate the flap, you can use a scleral patch graft and change the location of the flap. So in conclusion, deep sclerectomy is highly dependent on the technical skills of the surgeon. It has a long surgical learning curve, during which the surgical time will be longer, the initial outcome will not be very satisfactory. And it's an important and safe, effective alternative to conventional surgery. Of course, it's an extraocular, non-penetrating procedure, so serious complications are avoided. And I'm done. Thank you so much.
Thank you, Abeer. Thank you very much for this beautiful lecture about the deep sclerectomy. Deep sclerectomy in childhood glaucoma is challenging because probably we are few in the world that we are performing this procedure. When we talk in the world about DS in children, people look at us like we are crazy. The results that we have with the deep sclerectomy are good, and I think it's a procedure that we should promote it, and more than that, publish our results because they are good. Thank you very much for your nice and enlightening lecture. I would like to ask you something. In Europe, experience, in your opinion, when you were in the learning curve of the deep sclerectomy, what it was the most difficult step?
Most difficult step. I think the exposure was a little bit difficult at first, and also creating the deep flap. Like if you don't keep the eye in the same plane, I was like not doing the same depth in both nasal and temporal sides. So I got a lot of tears of the superficial flap or uneven thickness. This was what I'm facing most of the time.
Okay. I didn't see that you mentioned the paracentesis and when you are doing the procedure. I mean, as a routine, are you using paracentesis before performing the deep flap?
No, I never do paracentesis. Usually when I check the IOP before the surgery, the patient would be on anti-glaucoma, and it's like it doesn't exceed 20. So I never need to do paracentesis.
And in the case that you have perforation, how do you handle this? I mean, without paracentesis?
Yeah, I had one case of perforation. I had to do paracentesis with the needle and like reform the AC with the BSS and do iridectomy. But I made it after the perforation happened.
Okay. I don't know, Dr. Schargel is with us. I mean, Dr. Schargel, do you have any opinion or any recommendation regarding the deep sclerectomy, because you are in the glaucoma division? I mean, because this was a wonderful lecture, but anything that you want to add as a tip or as a trick during the deep sclerectomy?
Thank you for the excellent presentation, and thank you, Gorka, for allowing me to give some ideas. I totally agree with the presentation she did, and I think that the tips are key for the success of the surgery. One of the things that I will add regarding, for example, the peeling of the Schlem canal, only peel if you see that there is something that can be peeled. Sometimes we try to peel and the Schlem canal, as Dr. Abeer mentioned, it's already removed with the deep flap. And then if you try to grab the tissues in that area, you eventually are gonna perforate. The other thing is the worst intraoperatory complication of a deep sclerectomy is a trabeculectomy. So when you are working on a deep sclerectomy in a childhood or in any patient, if you don't see percolation of the aqueous humor, keep digging until happens two conditions: or you see the aqueous humor coming out, or you perforate. Because if you don't do that, you are curving into the tissue, but you are not completing the surgery. And the immediate effect of this condition is the next day, the pressure is going to be high. The normal thing, as you probably all experience, is that the next day, the pressure is going to be low. And in quite often presentations, we will have choroidals. So those are basically, I think, the most important steps. She mentioned it's very important to get very deep. And the other thing that is really nice is that we have, as you also mentioned, Gorka, we had a lot of nice experience with the DS. In Europe, we did a lot in adults, never in kids. And you can tell to the world in general that we have very good results, and it can be perfectly our first option, surgical option in kids. Thank you. Thank you for this great presentation.
Thank you, Konrad. Thank you very much. I have a question from Dr. Rubio, who says, if the thickness of the sclera is so critical, is it possible to use the OCT with the microscope to guide the dissection?
I don't know if the question is, I guess, for Dr. Abeer.
Abeer, but also you're more than welcome. Let's give the chance to Abeer, and then you can complete it, please.
He means anterior segment OCT?
Yes, with the microscope. You know
I don't have experience with this.
Okay,
Dr.
Dr.
Konrad.
Well, I don't use it. I can tell you my experience at the beginning. We were trying to figure out precisely if we could get, in a way, standardize the different thickness of the superficial that should be in a standard sclera of 1,000 microns. You should do it, the superficial, between 300 to 400, and then around 500 to 600 microns the deep. So I was using the diamond knife that we use for RK, but it doesn't work. You know, there is nothing better to do the flaps than the experience and the eye. There is no system, no OCT, no diamond knife with a micron setting, nothing of that work as good. Not even the Excision laser for that can be used for deep sclerectomy. It doesn't work as good as a skilled, trained, and with experienced surgeons doing it.
Thank you, Dr. Schargel. There is a question from Dr. Rami Kassar that says, what about using femtosecond laser to perform non-perforating deep sclerectomy? Did this can improve the learning curve? Nice question. Abeer?
Again, no, no comment regarding this. I don't have experience with femtosecond.
You know, it's a nice question. The femtosecond, yeah. I mean, regarding the architecture of the wound, and could be very interesting. No, we don't have experience in KKH with this technique, but could be think about it. We could use this in some point. I would like to mention something regarding one of the tricks in the deep sclerectomy, and I learned that from Dr. Schargel when it's about the name. It's called deep sclerectomy, so it means that you need to go really, really deep, and then really deep means suprachoroidal. One of the failure that we see when people in the learning curve is that we are afraid to go deep and we go shallow, and when we go shallow, we fail, we miss the Schlenk canal. So don't be afraid to go really, really deep. The practical tip could be is brown, I mean, suprachoroidal space, you're gonna see brown with a bare white bands of collagen. This is the plane that you're never gonna miss the Schlenk canal in primary congenital glaucoma. I don't know if Dr. Shamrani is here, Mohammed Shamrani. He do the deep sclerectomy with the conjunctiva, opening the conjunctiva, I mean, going in the opposite side, not like Abeer do it, you do on the opposite side. Dr. Shamrani, do you have any comment regarding this?
Hello, good afternoon, everyone. And,
welcome.
Thank you for the nice video presentation of this lecture and regarding this procedure. I enjoy it. I used to use the fornix incision, which is considered as limbal flap in my cases. And my idea of using that, yes, sometimes get exposure a little bit difficult, but if you are trained to do it, then you have good exposure. And my idea that in the first post-op day, I'm not afraid of any leak. So if I found like the ACs to the shallower side, I'm not afraid that there is leaking outside. Maybe over filtration under the conjunctiva, but not going outside that I'm risking endophthalmitis and this thing. So this is why I use usually the conjunctiva, the limbal based flap conjunctival incision, which is fornix incision, to do my deep sclerectomy.
Any tip, Dr. Shamrani, that you can give us to master the deep sclerectomy?
It was a very nice lecture by Dr. Abeer. Just as she said, it's a delicate procedure that someone has to be careful during his dissection, and to have, as you said, real deep flap. Usually I just leave very small fibers over the choroid. Otherwise, you will have no filtration to this uveal tract, and then you will need to go again for the procedure. If I have perforation of the during putting my tracking suture, then I found it become very difficult to complete the procedure because you have to have a firm globe to create your dissection in a good plane. I have one case that perforated, and I did the procedure, it failed with difficulty, then it failed, and I need to do another one. I think now if I have a case of perforation and I cannot maintain the good pressure in the eye, I may just abort my procedure and try to do it another time with this leaking stopped. This is what I may do if I face a case of perforation that I cannot maintain the integrity of the globe.
Thank you very much, Dr. Shamrani, and thank you very much for your valuable tips. Dr. Ahmed Alia is asking if, Abeer, if you inject Helan during the procedure, do you remove it at the end or leave it?
I don't enter the AC at all. Like in all my procedures that I've had done so far, I don't use OVD.
Okay.
So,
Okay. But in case of somebody in the audience that want to participate that has, I mean, perforation or use Helan or viscoelastic in the case, do they remove it or do they keep it? This is a nice question. Dr. Schargel, any idea? Okay, it is valid to keep it or is valid to leave it? Usually, when I have perforation, usually I keep I use Helan and I keep it in the AC. It's going to help me, especially my concern with the perforation. More than the perforation is the consequences of the perforation, like a choroidal detachment. No, the huge. I mean, I think that the sudden decompression is one of our enemies in the procedure. I suggest when you are in the learning curve that you do paracentesis before, because in case that you face the perforation, the management is going to be easier because you already have an entrance port to work and to deal with the feeling with air, with feeling with visco or feeling with PSS. So any other questions from the audience? I would like to be very grateful with you, Abeer, because this nice presentation was very enlightened, and I'm very proud of you as a consultant in our division. Okay, so
thank you so much.
If we don't have other questions, we can adjourn the session, and thank you all the audience for your participation. Thank you so much.
Thank you.